Good evening. Our endometriosis event will start very soon. Thank you. Good evening. Tonight's event on endometriosis will begin very soon. Thank you. Good evening. Thank you for joining us. The endometriosis event will begin very soon. Good evening. Thank you for joining us for tonight's event on endometriosis. As an introduction, we're going to take you through some instructions on how you can interact with the speaker and the organisers. The event is being hosted on MS Teams Live. MS Teams is a secure platform. However, there is a 20 to 40 second delay on the presentation, so you will actually be hearing what the presenter or myself has said between 20 and 40 seconds ago. Nobody on this evening's event, including myself, the organiser or the presenter, and any other of the attendees can see you, so nobody can see or hear you this evening, but you are able to interact with the organiser and the presenter via the Q&A panel. We will turn on the Q&A functionality after the introduction. The Q&A panel can be found to the right of your screen. You can toggle this panel on and off using the comments button in the top right-hand corner. And you can click ask a question to the organiser and/or presenters. We understand tonight's event is quite an emotive event where we have a lot of patients suffering as a result of this terrible condition. It's going to be very difficult for Dr. Ahmad, our speaker this evening, to be able to answer personal questions relating to your personal circumstances. Obviously, a doctor will need to know medical history. So if you're asking regarding your personal circumstances, it will be difficult to answer questions. But if your questions are relating to generic symptoms and possible treatments, then of course we'll do our best to answer as many questions as possible. If we aren't able to get through to all the questions, we will come back to the questions on our social media account, and so we will submit the questions to the speaker this evening, Dr. Ahmad, who will then answer the questions, and then we'll submit them on social media. So if you do ask a question, we will do our very best to make sure they were all answered for you. You're able to type your name in and your question, or you can choose to post your question anonymously if you prefer so, and then you can click the little arrow to send. All the questions will come into a moderator first, and if they're deemed appropriate and suitable, then we will submit them to the public forum so everybody can see the questions that you're answering. Once you've submitted a question, they will appear under the My Questions tab. And you can view moderator approved questions from other presenters. Click onto the featured tab. When you're viewing the approved questions, you'll be notified by a red dot when you have a response to your particular question, and you can interact with other questions by clicking on the thumbs up button. So that's a quick brief run through of how to interact with us via Teams Live. I'm going to turn on the Q&A functionality live very shortly. In the meantime, I'd like to introduce your speaker for this evening. We're very lucky to have with us Dr. Gaity Ahmad, who is a specialist gynaecologist who specialises in endometriosis. Dr. Ahmad, I'm just going to send live your video feed. If you could unmute your microphone, your video is live now, and if you could share your screen so that we can get the presentation up, that would be fantastic.
Are you able to see it?
Not yet, no. I can see you, but not your presentation. And just for the audience, the Q&A is now open.
Can you see now?
No, not yet.
Okay. Yeah, no, that one. And it's that one. Can you see now?
It's not in presentation mode, so if you could just pop it in presentation mode first before you share.
Okay, put in presentation first and then.
While we're waiting for the slides to come up, we are hosting from the Highfield Hospital, which is a hospital based in Rochdale. We are a private hospital, but we do see and treat NHS patients, and you can be referred directly to Dr. Ahmad as a private patient or as an NHS patient via your GP. Thank you, Dr. Ahmad. That's now live. I'm just going to send your slides live, and they're live now. Thank you. I'm handing over to you now.
Okay. Thank you, everyone, for joining in, and good evening, everyone. And thanks for the organizers, especially Vicky and Graham, who have worked tirelessly to get this event live today. And obviously my team at Royal Oldham Hospital, who have worked to get this all happen, and also to help me prepare this presentation. So for all those of you who don't know me, I am Gaity Ahmad. I'm one of the consultant obstetrician gynecologists, and I am primarily based at Royal Oldham Hospital, but I do 2 sessions a week at Highfield Hospital in Rochdale. I lead the endometriosis service at Royal Oldham Hospital, and I am also a senior lecturer at Manchester University. Now, before I start the presentation that I have here, I would just like to apologize in advance that if I use any medical terms or any thing that you don't understand or you want to ask any questions, please feed in as Vicky has explained, and we will try and get back to you as quickly as we can, and hopefully tonight or on the social media in the next couple of days. I'm going to talk about, as Vicky has already alluded to, about endometriosis. So what exactly is endometriosis? It is a condition where cells that are similar to the lining of the womb grow outside the womb. So most of the time they grow within the pelvis, so they can involve your ovaries, tubes, and other organs within the pelvis, like bladder, bowel. Sometimes, on rare occasions, they can also migrate to other organs in the body. For example, they can affect the diaphragm, the lungs, the various joints in the body. Now, what causes endometriosis? That is a question that is still, I don't think, answered, and that is the reason why it is so difficult to diagnose endometriosis or to treat it, because we don't really know how it actually starts, what happens. So the most commonly talked about cause is that there is retrograde menstruation. So the menstrual fluid travels through the womb, through the tubes, and goes and gets implanted within the pelvis, so in the ovaries or areas around that, and gets stuck there, and that causes endometriosis. But if that was the case, then all women would have endometriosis, because we all have retrograde menstruation. So then there was some research, and some scientists came up with the idea that this is actually an autoimmune condition, or it is hereditary, because endometriosis does tend to run in families. So the problem, we all know this is a huge public health issue. 1 in 10 women have in the reproductive age group suffer from endometriosis. So if you're talking about 10% of women, then worldwide you're talking about 200 million women with endometriosis. And if we look at a group of women who find it difficult to get pregnant, then in them, the incidence or prevalence of endometriosis is even more. It is around 30 to 50%. So 1 in 3 or 1 in 2 women will have endometriosis in those women who are specifically trying to get pregnant and are finding it hard to get pregnant. So if we just focus on on United Kingdom, there are around 2 million women who have endometriosis. So this is kind of equal to the number of women who have diabetes. There is plenty of research going around about diabetes, and there are funds available to do those research. It is so if you have, for example, if you have diabetes, your prescriptions are free. But women who have endometriosis, their prescriptions are not free. The endometriosis is a chronic disease, and women need their medication on a long-term basis, but they have to pay for prescription. So there is a lot of inequality. There's a lot of things that we don't know about this condition, and that is why we're trying to raise awareness of this condition. And of course, I'm sure most of you will agree that there is a delay in diagnosing endometriosis, and this delay can range to anywhere from 7 to 11 years, depending on which study you look at. So, sorry, my next slide, I'm sorry I shared it. My next slide is a little bit graphic representation of a picture that I took during a laparoscopy that I performed, and it kind of just explains how endometriosis can affect various organs. So if any of you are not keen on looking at that picture, please could you turn away and then come back to the presentation in a couple of minutes. So this is a slide which shows basically how the organs can get stuck to each other when you have endometriosis. Because what happens is that these little cells, which are similar to the cells of the lining of the womb, they go and get stuck in the pelvis. And when they are in the pelvis, every time when you have a menstrual cycle, these cells also bleed. When they bleed, then this blood has nowhere to get out, and therefore the healing in the body happens by forming scar tissue. So one of the presenting sign of endometriosis is a lot of scar tissue, and you can see here that the tubes, the ovaries, these white structures are the ovaries. The tubular structures here are the tubes, and you can see they are stuck to the back of the uterus. This is the uterus, and this is the bowel, which is also stuck to the back of the uterus. So basically what I'm trying to say here is that this is a disease which causes a lot of scar tissue, and that scar tissue causes pain. So how do we diagnose endometriosis? There are women who have endometriosis can present with various symptoms, but one of the most common symptoms is chronic pelvic pain. So why I have put it on the top of the list is because the pain does not necessarily have to be associated with menstrual cycle. It doesn't have to be a cyclical pelvic pain. You can get pain at any time during the month. It doesn't have to be related to your periods. And that is something that I find all the time, that doctors, even not necessarily GPs, but even doctors in the secondary care tend to dismiss sort of diagnosis of endometriosis by saying that the pain is not at the time of the periods, or it is not related to the menstrual cycle. So then women can present with pain during periods, pain during sexual intercourse. They can be period related or cyclical bowel symptoms. So by that we mean pain during bowel movements, which can be at the time of the periods, or it can be at the time of the periods, or it can be outside the, when you're not on a period. Similarly, there can be cyclical urinary symptoms, which can be at the time of the periods, or it can be not related to the periods. And one of the most important things that we have to keep in mind is that anyone who's trying to get pregnant, they have up to 30 to 50% chance of having endometriosis as an underlying cause of their difficulty in getting pregnant. So how do we diagnose endometriosis? As I alluded to in my previous slide, history is extremely important, and therefore it is important that when you present to us, we listen to your problems. So if suppose you have just got cyclical, let's say bowel symptoms or painful bowel symptoms, that can also just point as much to a diagnosis of endometriosis as painful periods. So history is important. Then obviously when you attend to your doctor's practice, to your doctor's surgery, or you see a consultant in secondary care, examination is important. In examination, we can sometimes find physical signs of endometriosis in the form of lumps, or we can find swelling, which can be a sign of ovarian cyst. Or women can just find the examination extremely uncomfortable or very painful, and that can also point to a diagnosis of endometriosis. Now, it is on purpose that I have put ultrasound scan there, because I just want to highlight that, if you present to primary care, to your GP or to us, we always say that, we always send you for an ultrasound scan. So I just want to highlight the fact that a negative pelvic ultrasound scan does not rule out endometriosis. So suppose you have cyclical pelvic pain, you have pain during periods or pain during sex, and you go for a ultrasound scan and nothing is picked up on ultrasound scan. That does not rule out an endometriosis. Of course, we can pick up ovarian cyst, and endometriosis can sometimes present as ovarian cyst. So that is one thing that can be picked up on ultrasound scan, but negative ultrasound scan does not rule out endometriosis. There's also a specific reason why I have put MRI scan, because I do get some patients who request that, can they be sent for an MRI scan to diagnose endometriosis? So I just want to give you certain figures to explain to you that how unreliable MRI scan is for screening endometriosis. So, for example, let's say if I do MRI scan on 100 women who have got endometriosis, MRI scan will only pick up endometriosis in 30 women. So there will be 70 women out of 100 who will have an MRI scan, and still not, MRI scan will not be diagnostic of endometriosis. MRI scan is a good tool to find out the extent of endometriosis in women who have severe disease. So in those women where bowel is involved, where there is thick a disease, where there is nodules there, things like that, where there is advanced disease, MRI scan is helpful in telling us the extent of the disease, but it is not a diagnostic test. It is not something that picks up a mild, moderate amount of endometriosis. So then you will obviously question, then how do we confirm that anybody has got endometriosis? For confirmation of endometriosis, what we have to do is laparoscopy is the gold standard. Now, laparoscopy is, I'm sorry if you all know about it, but laparoscopy is just for those of you who don't know what laparoscopy is. It is it's a camera test which is used for diagnosing endometriosis. It is performed under anesthesia, under general anesthesia. So you're put to sleep, and then a camera test is performed to find out endometriosis. And it is a gold standard, and the sensitivity is very high. The pickup rate is very high for endometriosis. But just a note of caution that it works best with people who know, who have special interest in endometriosis, so that they can pick up the disease more. So, because endometriosis can present in various forms, and as the lead of endometriosis service in Oldham Hospital, I have come across time and time again where women have had laparoscopy in other hospitals, and they've been told that they don't have endometriosis. And I have gone back in for various reasons and done another laparoscopy and have picked up endometriosis. So even the NICE recommends that laparoscopy should be offered and performed by clinicians who are specifically trained in minimal access or laparoscopic surgery and have a special interest in endometriosis. So let's say we've performed a laparoscopy and we have found that there is endometriosis. How do we manage it? So before I go into details about management, I think the thing that I would like to highlight is that there will be a group of women who have an incidental diagnosis of endometriosis. So, for example, they come in for let's say sterilization procedure, and we do a laparoscopy and we find that they've got endometriosis. It is our duty to obviously let the women know that they've got endometriosis, but it is not necessary to treat this condition if there are no symptoms. So what we're really treating in endometriosis is the symptom side of things, and especially what the woman wants. What is actually the end point? So let's start with the conservative management. So let's say there are various painkillers available to help in relieving the pelvic pain that is associated with disease, and they can range from anywhere starting from paracetamol, non-steroidal anti-inflammatory drugs like ibuprofen, naproxen, or more specific drugs like, for example, drugs that are used to treat neuropathic pain. Neuropathic pain is nerve-related pain, and as I've explained in my previous slides, that because endometriosis can infiltrate or can involve the nerves, so sometimes if women have deep endometriosis, these drugs work. For example, amitriptyline and pregabalin. Then there are certain other groups of drugs which are more commonly used to treat depression, but they have also been proven to help relieve pain in women with endometriosis. Then obviously there are a group of drugs with in the morphine family, or they are called as opiates, and they are codeine, tramadol, and morphine, and they can also be used to treat more severe pain. Now, before I move on to the next next available option, I just would like to highlight one thing. There is no science there is no study that tells us that one form of management is better than the other. So there is no trial that has proven that surgery is better than medical management. And there is no trial that has proven that any one form of medical management is better than the other. So all of these medications work in 70 to 80% of women. So there will be 20 out of 100 or 2 out of 10 women who will not benefit even from surgery, or who will not benefit from the medical treatment option. And usually women choose one treatment option over another based on the side effect profile of the various medications available. or whether they want, whether pregnancy is the main issue for them. So subfertility is the main thing, because if subfertility is the main issue, then surgical treatment option or simple pain relief like paracetamol is the only two options available. Hormonal treatment obviously is not available, because hormonal treatment will obviously make it even more difficult or impossible to get pregnant. So if we go into a little bit detail about the hormone treatment options available are combined oral contraceptive pill, or the mini pill for or the progestogens. They are all one. So the progestogens or the mini pill or the Depo-Provera injections or the Implanon, these are all one group of hormones, and the side effect of these hormones are mainly irregular vaginal bleeding, breast tenderness, bloating, mood changes. So there may be a cohort of women who say that, well, I don't want all these medications because, I already suffer from mood changes and I don't want to go on these hormones because they may make my condition worse. And that is fair enough. So then we go to the next available option, which is the GnRH analogues. And you may have heard about them. The commercial name is Prostat or Zoladex, and I will talk to you a little bit more in detail in my next slide. The next option available is surgery, and surgery can be divided into two parts. There could be conservative surgery, where we just go in, cut out specific endometriosis, or it can be definitive surgery in the form of doing a hysterectomy, plus removing all the endometriosis, plus either conserving the ovaries or removing the ovaries, depending on the preference of individual preference. So a little bit about GnRH analogues. They come, you may have heard about them, they come in the form of Prostat or Zoladex, and they come in the form of injections, and they can be given either monthly or 3 monthly. And what they actually do is they mimic a hormone that is produced in the brain, and they completely switch off your ovaries. So when they switch off your ovaries, the ovaries are unable to produce any estrogen. And there is a group of, obviously endometriosis is considered to be estrogen dependent. So when we switch off the estrogen, we believe that that the pain associated with endometriosis gets better. So therefore the GnRH analogues, that's how they work. The side effects obviously are self-explanatory, because they produce all those symptoms that women get when they go through the menopause. So hot flushes, night sweats, and that's why we usually provide HRT with these injections to minimize the side effects. Now, if suppose somebody has, let's say, a strong family history of breast cancer and does not want to take HRT, or there are any other issues, they have heart disease or anything else, and they do not want to take HRT, they can still take these injections for 6 months. But after that, these injections cannot be given, because they have a negative effect on the strength of the bone if they are not given with the HRT. So they can only be given for 6 months, but if somebody is happy to take HRT with these injections, then they can be given for up to 2 years. After that, they're not licensed to be used. I do have a cohort of women and some experience in giving these injections long-term to certain women after appropriate counseling. If this is the only thing that works for them, then, and they're fully aware of the fact that this is not a licensed drug. It is not licensed to use after more than 2 years. But if we still come to an agreement that this is the only thing that works and women are happy to go ahead with them, then what we do is we do a yearly bone scan, so that we ensure that the bone density is not affected, or as soon as we pick up that there is even slight deviation or deterioration in the bone density, we stop these injections straight away. Because they have an effect on bone density, we obviously are reluctant to use it in very young women, those who are in their late teens or early 20s. So we next come to the surgery. part of it. So of course, as I explained in my previous slide, laparoscopy is the gold standard, not only for diagnosis, but if we diagnose it at the time, we can treat it there and then. By treating, I mean cutting it out and sending it for histological confirmation, so that the pathologist can look under the microscope and confirm that this is endometriosis. And this is important for some women because they do want to know what exactly is the problem, and they want a confirmation, they want a diagnosis. So it is important for diagnosis as well as for treatment. So in endometriosis, what we do is obviously for any surgical procedure that we do carries risks with it. Especially if there is a lot of scarring there, the risks increase. So let's say if we are just performing a diagnostic laparoscopy and just treating mild endometriosis, the risks are different compared to if we are treating endometriosis in somebody who has got bowel endometriosis or bladder endometriosis and a lot of scar tissue. So the complications range from anywhere between 2 to 3 in 1,000 to 2 to 3 in 100, depending on the extent of the disease. So if we are treating mild moderate disease, or we are just doing a diagnostic laparoscopy, then the risks are much smaller compared to risks if we are treating very significant or very severe stage of endometriosis. So before I go on to the next slide, one more thing I want to explain is that all severe endometriosis have to be treated within an endometriosis center, and there are several endometriosis center recognized nationally by the British Society of Gynaecologist, and women with deep endometriosis or severe endometriosis should be referred to those centers and treated there. And the one closest to Rochdale is in Oldham. So the next slide again has got a few pictures taken at the time of a laparoscopy, which I performed a couple of months ago. So those of you who don't want to look at the picture, please turn away, because it has a graphic representation of the scarring and then post-surgical picture as to how it looks once the endometriosis has been treated. So this is stage 4 endometriosis. So I'm sorry for the, it says stage 6, but what it actually means is stage 4. So there is an arrow that is explaining that is the uterus, the round structure there in the front. This is the tube here. This is the bowel, the pale bit here. And this is again the tube of the left side, and it is stuck to the back of the uterus. The bowel is stuck to the back of the uterus. Both the ovaries, which should normally be free, are stuck to the back of the uterus. And this all scar tissue because of endometriosis. So, you know, usually if you Google endometriosis, the pictures that come up, they show bright, dark blue, black spots of disease. But that is a very classical picture, and that is only present in a small proportion of women. Majority of the women present with scarring really rather than anything else. And sometimes it is hidden behind other organs. And therefore, if, you have to be careful and do a very systematic laparoscopy to find the disease. And so we obviously systematically removed all the scar tissue and mobilized all these organs back to their normal anatomical positions, mobilized the bowel away, removed all the endometriosis, and at the end of the procedure, all the organs are back in their normal places, ovaries are back in their normal place, tubes are back in their normal place. As you can see, bowel is no longer stuck to the back of the uterus. And this is how it should appear once the surgery has happened. So there is also a lot of talk and a lot of interest on alternative therapies, and there are some studies that have been set up only recently to look at alternative therapies. There is some low quality evidence to suggest that acupuncture may be more useful than Chinese herbal medication to help relieve pain associated with endometriosis. I have not come across any evidence about the herbal medications yet, and absolutely no evidence to suggest that they improve fertility outcomes. Now, with regards to diet, there's a lot of obviously talk about various forms of diet helping in pain associated with endometriosis. Now, there is no research that I have come across which has supported the use of certain types of diet or advise women not to have certain types of diet to help improve their pain associated with endometriosis. A trial has been registered which is comparing Mediterranean diet and physical exercise and looking at its effect on endometriosis, but the results haven't been published yet. So there is regarding the diet, I always say that there is at least 15 to 20% of women who have been diagnosed with IBS or IBS related symptoms, they have endometriosis. And because in a lot of women, both the conditions coexist, so if you treat one condition properly, the other somehow tends to improve, or you can manage the other condition a bit better. So therefore, if somebody suffers with IBS type of symptoms, they have constipation or diarrhea, or certain types of diet irritate their bowel symptoms or make it worse, then we always obviously try and help improve those side of things before or at the same time as treating the endometriosis, because they kind of support each other. Then comes the question of physical exercise. I mean, I have not come across any direct studies comparing exercise with relieving pain in endometriosis, but we know that physical exercise helps improve general physical and mental well-being, and therefore I think it helps in generally coping with the condition. So a little bit about the endometriosis centers. So as I alluded to in my previous slide, that deep endometriosis or stage 4 endometriosis can only be and should only be treated within an endometriosis center. There are several endometriosis centers all around in the country. We have one in Royal Oldham Hospital, which is a nationally recognized endometriosis center. The advantage of the endometriosis center is that we work as a team. So there's not one person doing it, doing surgery. We have a team of colorectal surgeons, consultants with interest in subfertility, radiologists, urologist and specialist nurse, and we all work together. We have a weekly meeting. We discuss the important, all cases with deep endometriosis or stage 4 disease, and then we come up with a management plan. We then explain that to the patient, and then the patient chooses as to what suits them best. Now, what we also do is that what has to happen within an endometriosis center is that when a woman is referred by the GP into an endometriosis center, they see one of the members of the team. They go through a questionnaire which asks them to score their quality of life and the pain that they're having. Then if they consent to putting their, if they're happy and they consent that for us to include this database, this questionnaire on the database, we complete this this information on the national database, which is, and this data is collected nationally. And also each center's data is monitored for quality assurance purposes. And we also keep a log of all the patients we have operated upon, their quality of life and pain scores before the surgery, and then we follow them up 6 months, 12 months, and 24 months after surgery, so that we can collect the information and compare to see whether the surgery that we are performing is working or not. So I'm going to present to you the data now from the endometriosis center. This is 6 years of data, and to explain to you that how it has helped, how the surgery has helped women in terms of relieving their pain. So we have operated upon 193, 198, some around that number of women with deep endometriosis, that is endometriosis involving involving bowel. And we have had 2 complications in 193 patients. One patient had a bowel injury, and it was then repaired, and she had a bag which was reversed in 7 months' time. This was a joint case with the bowel surgeon, so bowel surgeon was present right from the beginning. There was another patient who developed a narrowing of the pipe that brings the wee from kidney into the bladder, and that was managed conservatively, and the patient improved. So just to give you a little bit of background, that nationally the complication rate reported for for this sort of surgery is anywhere between 3 to 5%. Now, our complication rate is obviously much less than that. We are very conservative in terms of surgery, and we have easy access to the bowel surgeons being available. So if the case is discussed at the MDT, and the MDT then reports in the MDT meeting says that, yes, this patient has to be operated upon with the bowel surgeon being present right from the word go, then we only operate with the bowel surgeon right from the word go. The majority of these centers where I have some experience of working, or I have not working, I've spoken to the leads of those centers. They usually work in a way that they call the bowel surgeons when the problem has already arose. But in this case, in our case, that is not the case. The bowel surgeons are very closely involved. The urologist is very closely involved, and and they're there right from the beginning. And that's why we've managed to keep the complication rate quite low. However, this is quite a complicated surgery. So really, the women have to be counseled appropriately, and whichever center they choose to go, the center should be able to provide the statistics of their center rather than national statistics, because they differ from center to center. Now I will, the next slide, I'll present to you the pain scores. So this slide is a little bit busy, so I'll explain to you. So this is the 2 blue columns tell us the pain, premenstrual, that is obviously before the menstrual cycle begins, and menstrual pain. So the women scored their pain before they had surgery. So before they had surgery, the premenstrual pain was, they scored this pain as 7, and this pain improved. As you can see, they scored their pain around 4 at 6 months, and same 4 at 12 months, and sort of 4.5 at 24 months. So the pain improved significantly from baseline level of 7 to a baseline level of 4.6 in 24 months after surgery. But when we talk about pain relief, we're not sort of talking about complete sort of that after surgery they will have no pain. But what we are saying is that the pain has improved, and it has improved their quality of life. So look at if you focus on these on the lower part of the slide about the menstrual pain, they scored their menstrual pain to 8.3, and as you can see, this pain improved to 5 and sort of remained at 5 to up to 24 months when we have followed them. We're talking about this group of women who had surgery at Oldham Hospital. So the next slide is the non-cyclical pain. So non-cyclical pain is something that I'm very sort of specific about, because you see, if you have chronic pelvic pain, which is not related to your menstrual cycle, a lot of people will sort of tend to ignore, saying, oh, well, it's not related to periods, it can't be endometriosis. So here is the women scored their pelvic pain on an average of non-cyclical pain as 5.6, so let's say approximately 6, and it stayed to around 2.5 for up to 24 months. So there was a significant reduction in pelvic pain, non-cyclical pelvic pain. Now, pain during sex. So they scored this as 4.5, and that also halved. So it improved significantly at 6 months, 12 months, and 24 months, and it stayed sort of more or less constant. So Low back pain. Now, low back pain is another thing, which is which, although the NICE does not does not put this as a diagnostic as a symptom of endometriosis, but I get a lot of women with just low back pain. After obviously musculoskeletal problems have been ruled out, I do think that women can present with low back pain as a cause of endometriosis because of the scarring that happens, the scarring that affects the nerves, and that can sometimes just present as low back pain or pain radiating down the legs. So you can see the women scored their low back pain as 5.8 before the surgery, and that improved to 3.9. So it stayed around 3.5 at 6 months, 12 months, and 24 months post-surgery. Quality of life. This is actually what really matters, and you can see the quality of life improved from around 56 to 75, 76, and 70 at 24 months. So, it helped this group of women. Bowel symptoms. So pain when opening bowels when on a period. So you can see that also improved from 5.5 to 3.2. And similarly, non-cyclical pain when opening bowels. So not related to the menstrual cycle, but you have just pain when you open your bowels, not necessarily at the time of the periods. And that also improved from 3.2 to 2.1, so making it statistically significant. So bowel frequency and incomplete emptying also improved. So I will talk a little bit about those women who obviously present with having difficulty in getting pregnant. So apart from simple analgesics like paracetamol, they don't have an option of choosing, to go on any hormones, because obviously hormones prevent our ovaries from acting or producing eggs. So they are not an option for women who are trying to get pregnant. So then comes obviously the surgical treatment. So there is evidence to suggest that if we treat surgically, so if we surgically remove endometriosis, it helps in improving chances of spontaneous conception, i.e. having a spontaneous pregnancy. So just if I explain it simply, so let's say we've got 20 women with mild, moderate amount of endometriosis. We divide them into two groups. In one group, we do nothing. In the other group, we treat all these women with a laparoscopy and remove the endometriosis. We follow this group of 10 women each in each group for a year. In the group where we have not done anything, we're just following them up, 2 or 3 out of 10 will get pregnant. In the group where we have surgically removed endometriosis, 7 out of 10 will get pregnant. So I am not saying that if someone has endometriosis, they can't get pregnant. But what I am saying is that endometriosis just makes it that much harder to get pregnant. And removing it helps and improves chances of spontaneous pregnancy. Now, one of the things that I want to highlight is that if there is a cyst in the ovary, so endometriosis is presenting as a cyst in the ovary, there is evidence to suggest that if we remove that cyst, it helps in improving chances of pregnancy. However, we have to keep in mind that every time we touch the ovary, we remove the cyst, we are removing some part of normal ovarian tissue. When we remove some part of a normal ovarian tissue as a side effect of the surgery that we are performing, we are reducing the ovarian reserve. As you all may already know, that we are all born with a fixed number of eggs in our ovaries. And when we remove the ovarian tissue, or we destroy a bit of ovarian tissue because we have done surgery, we are destroying some number of eggs. So the ovarian reserve is reducing. So this is a dilemma where women need to be counseled appropriately before agreeing for surgery, and especially for those who have already had surgery and then the cyst has come back. Now, if the opinion is really divided as to what do we do before if someone is going for IVF. Let's say if someone is going for IVF and they have endometriosis and they have no pain, the only problem is difficulty in getting pregnant. They are going for IVF. What should we do? Should we treat or not treat? Now, if you speak to experts in laparoscopic surgery, they will say, yes, we should treat. If you speak to experts in fertility or IVF group of consultants, they will say, oh, no, of course you shouldn't treat. As far as I can see, there is no good quality evidence to tell us that we should perform surgery for women who are, heading towards IVF or are already close to, getting on the IVF cycle. Unless they have pain, then of course we can offer them surgery, or they have such large cyst that the IVF team wants us to remove the cyst before they can proceed with the IVF. So I'm going to present some data from our center regarding surgery and its effect on fertility. So we collected some data from 2014 to 18. So this is data for 5 years. And we looked at the women that came to our hospital and were trying to get pregnant and had endometriosis, where we surgically removed the endometriosis. So 83% of women had never been pregnant. They were around 34, 35 years of age. After surgery, around 50% of women became pregnant within 13, 14 months of having the surgery. 80% of these women had a pregnancy that, continued till term. Now, 12% of women, which is a bit higher rate, developed had an ectopic pregnancy. Now, that is because, you may recall my previous slides, endometriosis does affect the tubes. And if the tubes are affected by endometriosis, then even if you have a pregnancy, there is an increased chance of pregnancy ending up as an ectopic pregnancy. And out of these, only 28% of the pregnancies went through IVF. The 70% of these pregnancies were spontaneous conception. So they came in, they were finding it difficult to get pregnant. They also had pain. We performed the surgery, and half of the women we performed surgery on got pregnant in 13, 14 months. Obviously, I'm sure all of you are aware of various support groups available where you can, you can contact them. And for the Endometriosis Center, there is this specialist nurse, and we have a specialist nurse, Lindsay Ferris, who obviously she has an email account and she tries to get in touch with as many women as she can technically possible. But obviously she's one person, and we are all stretched for resources. That is all from me. And thank you very much for joining. And I'm happy to take any questions.
I've summarised all the questions by theme.
Thank you, Dr. Ahmad. That was absolutely fantastic. We have had lots of questions, and we've been very busy trying to respond to some of them. And so apologies if we've not managed to get to your question yet, but we do have 39 published questions. So I'm going to start going through these now. We obviously, we'll start. Okay. So, is it possible to have endometriosis but not be visible through an ultrasound, including an internal ultrasound?
Yes. As I said, ultrasound is not a very good screening tool at all. So a negative ultrasound scan, so i.e. you find nothing on ultrasound scan and you could still have endometriosis.
Thank you. What are the best pain relief options for endometriosis? There's also a couple of linked questions to this one, which if you just bear me 1 second. Where are we? You carry on while I find it.
Okay, so that's fine. The pain relief, so there is no one specific medication that stands out. So there are various medications available, for example, paracetamol, ibuprofen. So the ibuprofen comes in the family of non-steroidal anti-inflammatory drugs. There is naproxen as well. Then we have certain specific drugs that are used for endometriosis related pain. and they work on the nerves. So they are drugs that are called amitriptyline or pregabalin. Then there are morphine-related drugs, and there are codeine and tramadol. But I'm sure if you contact your GP, or if you're in any, have been already referred to a specialist, they will go through and look at your allergies and what type of job you do, and whether you can, what medications you've already tried, and then, go to choose. Then together you can make an informed choice as to which suits you best.
I found the question that's related. Amitriptyline and gabapentin, what are the differences in effects?
Not a lot, really. They work similarly, and both are helpful in relieving pain associated with deep endometriosis when it involves the nerves. And they're both very helpful, but side effect profile is different. So some people feel very sleepy with gabapentin, and therefore, based on the side effect profile, people choose one medication over the other. There is no evidence really to tell us that one medication is any better than the other. Some women benefit with one and some with the other.
Thank you. We spoke earlier about endometriosis not being picked up on an ultrasound. Is it possible to have endometriosis not found during a laparoscopy?
Unfortunately, the science tells us that we should be able to find it, but as I explained alluded to in my slides, as the NICE guidelines say, that laparoscopy has to be performed by a clinician who is trained in laparoscopic surgery and has an interest in endometriosis. Otherwise, yes, unfortunately, endometriosis does get missed. I have had women in my experience who have had negative laparoscopies, but when I have gone in and seen there was endometriosis, whether that is because endometriosis was in microscopic stages before, it was very, very small and wasn't visible to the previous person that has performed, or whether it has been missed, it is difficult to say.
Thank you. Sorry. How do you monitor endometriosis after hormonal treatment and surgeries of deep infiltrating endometriosis? So how do you monitor it after?
So the NICE guidelines say that if women choose not to have surgery and they choose to have hormonal treatment or pain relief, the medications, then we should monitor them. They don't tell us how often we should monitor them, but in my practice, I arrange for them to have either an MRI scan every 6 months or an ultrasound scan. So if anybody is getting confused because it's a contradicting answer from the previous one, these women already have endometriosis. So we already know that this disease is very advanced, and we're talking about stage 4 disease where even ultrasound can pick it up. So either if they have a cyst, let's say, we monitor it through ultrasound. But if they have some disease that is involving bowel or bladder, we monitor it through MRI scan.
Thank you. Can superficial stage 1 endometriosis cause symptoms, or is this more likely to be due to a coexisting pathology?
Yeah, I'm sorry, I didn't talk about this bit. One of the problems with endometriosis is that small amount of disease can cause excruciating pain, and a lot of disease sometimes causes no symptoms whatsoever. So we sometimes go in to do a cesarean section, and we find that there is extensive endometriosis that neither the woman was aware of or had no symptoms at all. And sometimes we do a laparoscopy for somebody who's got very superficial, mild disease, but is in a lot of pain. So the amount of disease does not correlate to the severity of the symptoms and also the site of the pain. So you could have disease on the left side, but pain on the right side. That is entirely acceptable.
We've got a couple of questions that have come in regarding endometriosis returning after surgery. So one question is, can endometriosis return after surgery to remove it? And after a diagnostic laparoscopy and excision, what symptoms need to be present to obtain a further referral to the endometriosis centre? How regular should checkups and surgeries be?
So, sorry, Vicky, what was the first question?
Is it possible for it to return after removal?
Yeah. Unfortunately, if we follow up 10 women on whom we have performed surgery, 2 or 3 out of 10 will get it back in the next 10 years. So it does tend to come back. It is a chronic disease, and it is very difficult to predict who's going to get it back. There is some evidence to suggest that if we use after surgery long-term hormonal treatment, so we're talking by long-term, I mean 18 to 24 months of hormonal treatment, that it kind of delays the recurrence of the disease. And the recurrence is very difficult as well, because we don't know whether this is the disease that was left untreated at the first surgery, or whether this is new disease, or whether this was the disease that was at microscopic stage when we did the laparoscopy and it has gradually grown. So it was going to come anyway. It's not actually new disease. And in terms of monitoring, then if somebody is already within the endometriosis center and they have had surgical treatment, they will be followed for 24 months, every 6 months by a hospital appointment. And I think there was one question that if pain has come back after surgical treatment, when so if the pain has come back after surgical treatment, then they should seek advice and contact their GP, and they will refer them back.
Okay, and is it possible for endometriosis to return after a full hysterectomy?
So endometriosis, hysterectomy and endometriosis are one thing that I really, I can talk for the whole hour, on this, because in 20, 30, 40 years ago, anything that was, if women had any symptoms related to the menstrual cycle, hysterectomy was the treatment for it. But if women has only had hysterectomy and the endometriosis hasn't been treated, so I get women who have had, in other hospitals where they have had hysterectomy and they've got a lot of pain and they come back and then, well, the endometriosis wasn't treated at that time. They were only hysterectomy has been performed. So hysterectomy will only help if when the hysterectomy is being performed, all the endometriosis at the time is removed and informed choice and decision is made to remove the ovaries or not. So if we remove the ovaries and we remove the uterus and treat all the endometriosis, it is unlikely for the endometriosis to come back. But because we don't understand the disease, it is difficult to say that it cannot come back. But of course, if we haven't treated the endometriosis in the first instance and only done a hysterectomy, then women will be in pain. It won't treat anything.
We've got quite a few questions where people are asking about the links between endometriosis and other conditions. So I'm going to run through them quite quickly. So the first one is there any link between endometriosis and sciatica?
Mm-hmm. So that's what I was saying, that it's not sciatica, but there is women with endometriosis can get referred pain into their back and thighs. And that is because this endometriosis is so deep that it has caused fibrosis and scarring, and the nerves have got entrapped within this scarring. And that's why they get this pain shooting down the legs. And I have a few women where I have gone in and treated surgically and removed the scarring, and that has helped them in terms of relieving pelvic pain. But again, a word of caution, not everyone gets benefit, and it is very difficult to differentiate whether this is pure sciatica or this is related to endometriosis. It's only once you've treated the endometriosis and the pain gets better that you say, oh yes, it was because of endometriosis.
Is there a link between endometriosis and the immune system?
Yet, in terms of the etiology of why endometriosis happens, there is a group of scientists who believe that this is an autoimmune condition, and that's why you can get endometriosis in the lungs, in the shoulders, and you can even get endometriosis after menopause. So they think that it is to do with altered immune system, and that's why you get endometriosis. But the research is not of good quality in that area, so we don't have any one firm sort of cause for endometriosis.
Is migraine with aura related to endometriosis?
I am sorry, I haven't come across any studies to explain that.
Are there links with endometriosis and hypothyroidism?
I mean, hyperthyroidism can also be autoimmune. So maybe that way, but you know, not as a part of a study. I have not read as such specifically about hyperthyroidism linked to endometriosis, but I wonder that there can be an association with any autoimmune disease, because obviously there is a theory that endometriosis can be autoimmune. So I suppose it can be linked to it, but you know, it hasn't yet been proven specifically in any sort of trials.
Is there a link between the mesh implant and endometriosis?
No, not that I'm aware of.
Is there any known link between endometriosis and pituitary tumours?
No, not that I'm aware of.
Is fibroids related to endometriosis?
They coexist. There are some studies that have explained that they have sort of looked at this and have said that women with fibroids have an increased incidence of endometriosis. But I wonder whether this is more by chance rather than being etiologically related, because you see, fibroids are very, very common, and so is endometriosis. So it may just be incidental that they are linked to that they are present together. But yes, if someone has fibroids and if they have pelvic pain or any symptoms that I've alluded to, there is a possibility that they may have endometriosis.
Can physiotherapy help with endometriosis?
So I think I alluded to this in the beginning of my presentation, that a trial has been registered to look at physical exercise and its effect on endometriosis related pain, but direct correlation with physiotherapy in terms of published literature, good quality evidence isn't there. But I do think that physiotherapy and all sorts of physical exercises help in terms of coping and improving the general physical and mental well-being. So they do help in terms of coping with this chronic condition.
Thank you.
Thank you.
How does the Mirena coil affect endometriosis?
So there have been several trials which say that Mirena coil helps in terms of relieving endometriosis related pain, and all of these is the same. The Mirena coil contains a hormone which is a progesterone family. So for example, the mini pill, the implant, the Depo-Provera injections, they all belong to the same family. So what they do is they calm down the endometriosis. So a bit of the hormone from the coil gets absorbed and calms down the endometriosis, and that's why it helps in relieving pain. But exactly how Mirena coil acts is, open to questions.
We still have quite a few questions to get through, but we have closed the submission of new questions. We have had over 150 questions in total, so we are trying to get to as many as possible, but we're conscious that we don't want additional questions building up. You can, of course, contact us if you've got any specific questions, and we'll give you details at the end. So we're going to move on now to holistic therapies. Are there any holistic approach to treating endometriosis for those who don't want to turn to surgery or medication? And there's so is there anything along the lines of acupuncture or anything like that you would recommend?
Yeah, there is evidence to suggest that acupuncture works better than herbal medication, Chinese herbal therapy. There is a published Cochrane review on that. So yeah, acupuncture there's some evidence to suggest that acupuncture works, but there hasn't been any other published studies about any other holistic treatment. So unfortunately, because there is no evidence around them, I'm unable to sort of go into more detail about it.
And Dr. Ahmad, is there any lifestyle factors that could be causing endometriosis or making it worse, such as diet, heavy metals, environment, toxins?
So the diet thing, as I explained before, that there is one trial that has been registered about Mediterranean diet, looking at Mediterranean diet and the antioxidants that are in the Mediterranean diet, specifically looking at that and its role on endometriosis. However, there is no published evidence about any specific diet and whether it helps in endometriosis. But as I explained previously in my presentation, that in women who have IBS or IBS type of symptoms, they have an increased incidence of endometriosis. So they have around at least 15–20% of women who have IBS or IBS type of symptoms will also have endometriosis. And there is evidence to suggest that if we treat the IBS type of symptoms better and control and give them, advice, whatever diet makes the IBS symptoms worse, if they avoid that diet, that helps the IBS, but also somehow helps the endometriosis related pain. So obviously, if there is anything specific to anyone, so let's say they get an upset stomach with dairy products, or they make them feel bloated, and then if they stop the dairy products, then that helps from that point of view, but that also helps with the endometriosis related symptoms. But as such, there is no specific one diet that can help improve the symptoms.
Okay, we've as expected, we have got quite a few questions relating to fertility. Mm-hmm. There's one about how much harder it is to get pregnant with endometriosis, but I think you covered that in your presentations. That may have been asked earlier on. Mm-hmm. There are what solutions are available and what support is available for people who are trying to get pregnant and can't because of endometriosis?
So obviously contact your GP, and hopefully they will refer you straight into the endometriosis services. And usually consultants who have special interest in fertility work very closely with the endometriosis team. We work together, and there is obviously available treatment options available in the form of surgery, or if they IVF. Referral to IVF centers is also available.
Thank you. Is there anything to evidence or any evidence to suggest that endometriosis makes menopausal symptoms worse?
No, not that I'm aware of.
Can a miscarriage worsen the symptoms of endometriosis?
I think so, because obviously usually women who have endometriosis have a lot of pain at the time of the periods. That's one of the most common symptom, and whenever they bleed, because miscarriage is usually associated with bleeding, so pain may well be exacerbated because they have endometriosis.
How long do you have to wait to try and get pregnant following surgery to remove endometriosis?
There is no hard and fast rule to not try. You can try whenever you feel mentally and physically able to.
There's a couple of questions about a licensed injection that you were talking about.
Yes, prostate.
Yeah. So when you say the injection isn't licensed after 2 years, is that all, or are you able to go back on it after a break from it?
Yes. So if you have a break of 6 months and your bone density is normal, so you have a bone density scan and you have had a break of 6 months, you can go back on it. But people are very cautious. So it usually, I would suggest that if anyone is taking it off license, then they do it within an endometriosis center. So the women are followed very, very closely, because you see, even when there is no long-term published data on the effect of recovery of the bone density once you come off those injections. So suppose if someone is on these injections long term and they have a reduction in bone density and we stop the injections, we are not able to advise the woman as to whether the bone density will ever recover back to normal or not.
Thank you. We've got some more here. There's a couple of questions around different types of endometriosis. So endometriosis in the diaphragm and endometriosis, thoracic endometriosis. How do you check for those?
When we do the laparoscopy, we should be able to check that.
So you can check the diaphragm during and the thoracic as well?
No, we can't check the thoracic. For thoracic, we do a CT scan.
Okay.
But for diaphragmatic endometriosis, we check when we do the laparoscopy.
Okay. Can polycystic ovaries be partnered with endometriosis? Can it develop into endometriosis, or is it just a symptom that runs alongside?
I think it runs alongside. I don't think it can cause endometriosis.
Okay. Can a laparoscopy or diathermy affect fertility?
Not just diagnostic laparoscopy, but diathermy can. So if you're talking about diathermy to the ovary, as I alluded to in my talk before, so if suppose somebody has a cyst and we go in and remove it, so we always run the risk of removing some of the normal ovarian tissue. And when we remove normal ovarian tissue, we reduce the ovarian reserve. So that may have a negative effect on fertility. However, there is plenty of evidence to suggest that removing mild, moderate endometriosis from the pelvis and from the ovaries helps in improving chances of spontaneous conception.
Okay, thank you. Can endometriosis affect the bladder, more specifically loss of sensation to urinate and muscular stroke nerves?
Usually, what I have come across is when it affects the bladder, it causes pain during passing urine, and usually it is either related to the menstrual cycle, or even it can be unrelated to the menstrual cycle, or sometimes women can present with bleeding, with blood in urine, but I have not come across, affecting, what was the question, sorry, again, affecting the
bladder.
No, what effect on the bladder, sorry, can you read the question?
Oh, yeah, just 1 second, let me go back to it.
Nerves of the bladder, it was, I think it was
yes,
nerves,
yeah.
And causing any incontinence. If it affects the nerves, it usually causes incontinence. No is the answer to that. Usually it is pain or it is blood in urine.
Thank you. Does smoking cause endometriosis to worsen?
No, I have not come across any studies to suggest that.
Can birth control pills with higher levels of estrogen worsen endometriosis?
Unlikely. I mean, this is something that is quite debated quite heavily about, but actually the thing is, even with high level of estrogen, we are giving progestogens, so they are combined pill, so they kind of neutralize each other, and the high level of estrogen does not adversely affect the endometriosis.
I'm just going to interrupt the questions for somebody's put a post up, which I think may be quite comforting for quite a few people on the chat tonight. A lady's put on saying, it took me and my husband 11 years and IVF to eventually get our beautiful daughter. Please don't give up. So that's from one of the people on the chat tonight. So thank you for sharing your story. So I'm going to go back to some more questions. Is nausea a common symptom of endometriosis?
I don't think nausea is a common symptom, but I do think that if you have extreme pain, you can get nausea and even vomiting. And also you can get nausea as a side effect of the medication you are on, rather than directly related to endometriosis as per se.
Perfect, thank you. And acid reflux, is that related?
Again, the same thing, Vicky, that, it is a side effect of a medication. Of some of the painkillers can cause a lot of acid reflux, especially the medications like ibuprofen, naproxen, that sort of group. They can cause acid reflux. So it is, I think, more often than not related to the side effect of the medication rather than endometriosis per se.
What are your thoughts on IUD?
IUD is the Mirena coil that we use usually at the moment, and it does help. But obviously, we have to counsel women appropriately, and it has to be an informed choice. So what I come across is usually that women have had the Mirena coil, but without much counseling before, and therefore they're not prepared for the side effects. And the side effects can be, some women are just extremely sensitive to the small amount of hormone that gets absorbed from this IUD into the circulation. and they can develop side effects to the Mirena coil. So we need, of course, it works. When it works, it is perfect. It works, I would say, in 6 or 7 out of 10 women in terms of relieving pelvic pain. But when it doesn't work, it can cause side effects in the form of irregular vaginal bleeding, bloating, breast tenderness, mood changes. And some women are just very, very sensitive to these little doses of hormones. And if they haven't been counseled appropriately, then they're not happy with it, and we then have to remove it.
So can your AMH levels be affected by Prostat, HRT and having a Mirena coil?
AMH levels are usually done to assess the ovarian function, and they should not be affected by any of these medications. They are usually affected when we do the ovarian, when we do surgery on the ovaries. So that's what I was saying about the ovarian reserve. So if we obviously destroy the ovarian tissue, or it gets destroyed because of the surgery that we have done, the AMH levels vary, can be affected, and it can have a detrimental effect on AMH levels, but otherwise no.
Okay. Can endometriosis cause hair loss?
Medications, some of the medications associated with use for treatment of endometriosis can cause hair loss. So these injections that we are talking about, it has been shown that they can, in some women, they have caused hair loss. So the Zoladex, Prostat type of things. Endometriosis not per se, but some of the medications used can cause hair loss, and some of the hormone treatments especially. So again, counseling and making an informed choice is extremely important, and coming off the drug if they develop side effects.
Why is there such little research done on endometriosis found outside the pelvis in terms of numbers and treatments? Many women where, for example, endometriosis has been found on the diaphragm, nothing appears to get done and they're left in pain.
Yeah, I mean, there is not enough research for even for endometriosis in the pelvis, not enough research. And that's why all these campaigns are going on to raise the awareness, so that we can get funding to do good quality research, so that we can find medications that work, because the medications that we have at the moment have a failure rate of 30%. So 3 out of 10 women, these medications don't work. There is hardly any disease where, you will have medications that don't affect, don't help majority of the patients. So yes, there isn't enough research, and that's why we have all this drive to find out to set up new trials and find out new medications. Now, regarding the diaphragmatic endometriosis, if you are in a endometriosis center where they are not able to treat this endometriosis, then you should ask your team to refer you to a center where they are. There are some of us who do this type of surgery, and not all endometriosis centers are performing this. So please ask your doctor to refer you to centers where this surgery is being performed.
Dr. Ahmad, thank you so much for this. We are reaching the end of the questions. We're aiming to finish by 8 o'clock. I appreciate we're asking a lot of you this evening, and we're very, very grateful for everything you're doing. Is a pulling down sensation in the lower abdomen a symptom?
Yes, it can be.
Can endometriosis affect the likelihood of IVF success? I know you covered this in detail.
Yeah, I did cover this because this is a very controversial topic, and I did say that if you talk to the IVF doctors, they will say no, go straight for IVF. If you talk to the two consultants who do laparoscopic work and endometriosis surgery, they will say go and get the endometriosis sorted out first. There is no evidence as such. There's no good quality research to say that it improves the success rate of IVF, the endometriosis surgery. But we do perform surgery for women who have pain, and most of the women with endometriosis usually have pain and difficulty in getting pregnant together. So if both of them are the symptoms, then usually we offer surgery before referring them for IVF.
Thank you. What causes the extreme fatigue and brain fog?
So, I mean, there is, I think, I'm not sure. There is no research that tells us exactly how the endometriosis acts and causes fatigue, but fatigue has been reported as one of the symptoms. But it is difficult to find out why fatigue is happening with endometriosis. I suspect it is because of the extreme amount of pain that women are in, and also the fact that majority of the medications are, either don't work or make them, dizzy and as a side effect of the medication, like morphine-related drugs. And maybe that's why it's happening, but there is no sort of clear scientific evidence to suggest as to why endometriosis causes fatigue.
Can endometriosis cause vertigo?
I don't think so. I have not come across any study explaining that. But again, I suspect, Vicky, majority of the things are related to the side effects of the medication. And I suspect women already have endometriosis and they take morphine-related drugs, and they can cause a lot of side effects. So, some of it is that rather than related to the disease itself.
Thank you. Could there be a link between hypermobility and endometriosis?
Not that I'm aware of, but I am aware of the fact that some studies are being set up to look into that. Hypermobility and endometriosis, but I'm not aware of any link as such yet.
How common is endometriosis in a cesarean scar, and what is the most effective treatment, surgical or medical?
Both work. In my practice, I feel that the surgical treatment option is better, because I feel that the women I have treated, I have excised that area, and it is not a very complicated procedure. The risks are far fewer, and it helps in terms of relieving pain.
Thank you. Do you perform excision or ablation or both? And are your patient excision and are your patient results following a specific technique or just general laparoscopic surgery?
Say that again, sorry, Vicky.
Do you perform excision or ablation, which you answered excision? Are your results following a specific technique or just general laparoscopic surgery?
The results that I presented were excisional surgery that I have performed in women with rectovaginal, i.e. endometriosis involving bowel. So that was the, yeah.
If endometriosis has been diagnosed on the bowel stroke rectum and uterosacral ligaments, apologies if I'm pronouncing that incorrectly, should this always be operated on, or only if the pain from the endometriosis is affecting life enough?
So as I alluded to in the beginning of my presentation, endometriosis sometimes gets discovered incidentally. So let's say the woman has come in for laparoscopic sterilization, or we're doing a cesarean section and we find that they've got lots of endometriosis. We don't treat that. We only treat if treatment is only offered to women who are symptomatic. So if you've got symptoms of the disease, then of course, we can treat it, and we can treat it by medical management with, hormones or painkillers, or with surgery. So treatment is based on the symptoms and what do we want to achieve as an end result, not if we find it incidentally.
Can sexual activity cause endometriosis if sexual activity began very young, or no?
No.
We're coming to the end of the questions now. Is there a preferred age range to try for a child if you're suffering with a stage 4 endometriosis? Do you recommend an optimum age range?
There is no optimum age range, and I'll just say it. Usually it's men doing gynecology rather than women, and men just tell women to get pregnant and that'll solve all the answers. But it does not work like that, unfortunately. It is based on your choice, your career, your way of life, what you want to achieve. Obviously, in general, as we all grow older, the chances of pregnancy decline, but for endometriosis, if you're going to have surgery, then the maximum chances of pregnancy are in the first 12 to 18 months after surgery. So try to have the surgery at the time when you're ready to have the pregnancy, if it's only for pregnancy, and then, you know, aim for pregnancy in the next 12 to 18 months.
What, I'm not sure I understand this question. I'm hoping you will. What's the difference between endo and ado?
Adenomyosis, maybe.
Okay. Yes. Yeah.
So endometriosis is where the lining of cells similar to the lining of the womb grow outside the womb. So they grow into the ovaries, the tubes, the bowel, the bladder. Now, adenomyosis is a condition where the cells similar to the lining of the womb grow into the muscle of the womb. So again, if they grow into the muscle of the womb, every time we have a period, these cells also, multiply and bleed. But there is no outflow channel for this blood to come out, and therefore the blood collects within the muscle of the womb, and therefore this also presents as pelvic pain. It's a type of endometriosis.
Thank you. And the final question, timing this just right. Do endometriosis cells harm local cells?
Sorry, I didn't get the question.
Do endometriosis cells harm other cells in the body, harm local cells?
So they do not as such harm other cells, but so let's say when endometriosis grows, the cells grow, they can cause scarring and fibrosis, and other structures can get entrapped in it. So that is one thing. So they can, that's how they produce nerve-related pain or sciatica or pain radiating down the legs. There is another, there is also a question as to how endometriosis causes subfertility or makes it difficult for us to get pregnant. And there is one theory where they say that endometriosis produces some toxins which make it difficult for the embryo, for the fertilization to happen inside the tubes, and then for this embryo to get implanted inside the uterus. So there is some sort of debate that they produce some toxins that makes it difficult for us to get pregnant. Okay. Thank
you, Dr. Ahmad. That was absolutely brilliant. On behalf of everybody that we had attending tonight, it's been absolutely fantastic. We did our best. We had the questions open for over an hour, and we hope that we did get to answer everybody's question that was submitted. I appreciate that you may still have more questions. We would recommend you visiting your GP. We had a few comments that some GPs weren't forthcoming in referring onwards. Please remember you are able to see another GP at the practice for a second opinion. And as well, you know, if you feel you're not getting the support from a referred gynaecologist, again, you are able to seek a second opinion. Dr. Ahmad, I'll be delighted to welcome you as a private patient at Highfield Hospital, but also as an NHS patient, you would need to go and see your GP and specifically request to see her at Highfield. Graham, my colleague, who's been furiously helping me deal with and field the questions, thank you very much for your support tonight. Graham will be sending out a survey to everybody who attended and registered for this evening's event. It'd be really, really helpful if you could give us your feedback on how beneficial you found it, if you like this kind of event, whether you would like some more, is there any particular topics you would like us to cover on another session. BMI Healthcare are also doing a women's health campaign where endometriosis is going to form a really big part of that. So we will also be sending you a survey and would really appreciate your comments on your diagnosis and symptoms. So Dr. Ahmad, thank you so much for this evening. It's been absolutely fantastic. We had a fantastically large audience tonight, and we got through all the questions. So thank you so much for your help.
And Vicky, sorry, Vicky, can I just say that to all those women who are here, that, you know, just be persistent about the referral. And if somebody isn't taking you seriously, please try again. Please go to another GP, as you have said, in the practice. And I'm sure, you know, you'll be able to get help. And one of the reasons for this is for this whole evening is that we want to raise awareness. We want the women to be equipped with the knowledge and information so that they can challenge if anyone, you know, is ignoring their symptoms or not sending them in the right direction.
So the only thing I'd love to say is wishing everybody a lovely evening, what's left of it, and everybody stay fit and healthy. Thank you very much.
Thank you.